Welcome to this week's Deep Dive. Imagine for a moment you walk into the barn and your horse, usually so vibrant, seems off. Maybe they're pawing, looking at their flank, or just, duller than usual. You know something's seriously wrong, but what?
Yeah, that's a scary feeling.
It really is. Today, we're plunging into a critical, often baffling equine emergency that could look like many things, but demands very specific, rapid action. Equine Duodenitis Proximal Jejunitis, or DPJ.
Right.
Our mission: to untangle this complex condition from its puzzling causes to its intensive treatment and, frankly, its variable outcomes. We've pulled insights from comprehensive veterinary sources to give you the shortcut to understanding this severe challenge.
And this isn't just about getting a diagnosis label. It's really about understanding a severe inflammatory process deep within a horse's small intestine.
Okay.
And grasping why rapid informed action is so incredibly crucial. What's truly fascinating here is how many pieces of the puzzle sort of need to come together for effective management, and just how quickly the whole situation can escalate.
Yeah. Okay, let's unpack this then. For someone who might have heard the term DPJ but isn't entirely sure, what exactly is Equine Duodenitis Proximal Jejunitis? What parts of the horse are we even talking about here?
So DPJ is an acute inflammatory condition. It primarily targets the duodenum and the proximal jejunum.
Okay, the first bits of the small intestine.
Exactly. Think of them as the very first sections right after the stomach. Now, while those are the main areas, this inflammation can sometimes creep into other nearby parts too, like the pylorus, that's the exit from the stomach, and even the stomach itself, sometimes the esophagus. The core of what happens in DPJ is, well, severe inflammation, a complete lack of intestinal movement, which we call ileus.
Ileus is right.
And a really significant buildup of fluid and electrolytes, mostly in the stomach and that upper part of the small intestine.
Ah, so that's why we hear about so much fluid coming out. Because horses can't vomit, is that it?
Exactly. That's the key. Because horses can't vomit, this fluid has nowhere to go but back up into the stomach.
Wow.
It causes extreme distension, terrible pain. And yes, it leads to those large volumes of what we call nasogastric reflux.
Right, the tube down the nose.
Yeah, that reverse flow from the stomach.
Yes.
And this isn't just discomfort, it's a full-blown medical emergency. It can very quickly lead to systemic illness, shock, serious complications.
Okay.
Oh, and you might also hear it called proximal enteritis or sometimes anterior enteritis. Same thing, basically.
That's a powerful description of what's happening inside the horse. It sounds like such a rapid, critical process. But if we dig a bit deeper, what's actually causing this? Is there one single culprit? Or is it still, a bit of a mystery?
It's definitely more on the mystery side, which is one of the most baffling aspects of DPJ. The exact cause isn't fully pinned down. The general consensus is that it's likely multifactorial, meaning it's probably a syndrome caused by several interacting factors rather than just one single disease kicking it off. However, the theory with the most support, the strongest evidence, points towards bacterial toxin.
Okay, bacteria.
Well, specifically, toxigenic strains of Clostridium difficile. These produce toxins A and B, and they've been isolated from the gastric reflux in a pretty significant number of DPJ cases.
So specific bacteria producing these nasty toxins are the prime suspects. That makes sense, I guess.
Precisely. Research also suggests that Clostridium perfringens and maybe Salmonella species can be involved too, though maybe less consistently than C. diff.
Okay.
The thinking is that these toxins trigger severe inflammation, they damage the lining of the gut, the epithelium, and they cause this massive excessive secretion of fluid into the intestine.
Right.
But beyond bacteria, other factors have been proposed too. There are, anecdotal links, things vets see in practice to sudden dietary changes.
It's like switching feed too quickly?
Exactly. Or moving on to really lush pasture, maybe certain types of feed. Though direct scientific proof for that is a bit scarce, it's definitely something vets consider.
Okay.
We also look at mycotoxins. Those are fungal toxins that can be found in feed.
Right.
Even stressful events like, say, foaling or big changes in training routines, these might predispose a horse. Other theories include reduced blood flow or ischemia to the intestine, maybe damage by strong gale larvae, though that one's less commonly accepted now.
Okay.
And finally, something we're looking at more and more is an imbalance in the gut microbiome, what we call dysbiosis.
Dysbiosis, so the gut bacteria getting out of whack.
Exactly. When that healthy balance of bacteria in the gut gets thrown off, it can potentially lead to all sorts of problems, maybe including DPJ.
So that dietary change piece is something an owner actually has some control over, potentially, which is a powerful thought.
It is, yeah. Careful management there is always good practice.
So with all those potential causes swirling around, what would you actually see if a horse was suffering from DPJ? What are the key indicators that would make you think, okay, this is serious?
The clinical signs are quite distinct, but like you said, they can mimic other conditions, which is part of the challenge. First and foremost, you'd likely see colic abdominal pain. This can range from, mild discomfort, maybe just looking at the flank, to severe, really excruciating pain. But here's a critical point. The pain is often profoundly relieved by nasogastric decompression.
So the pain just melts away when you get that tube in and drain the fluid? That sounds like a huge clue.
It absolutely is. It's a massive clue and a key differentiator from, say, a twist that needs surgery, where tubing often doesn't help the pain much at all.
Okay.
The hallmark sign, though, the real classic sign, is that gastric reflux.
A fluid.
Yeah. Horses with DPJ produce just astonishingly large volumes of fluid via that nasogastric tube. We're talking liters, sometimes tens of liters per day.
Wow, tens of liters.
Oh, yeah. And this fluid, it's typically reddish-brown, often really foul-smelling, maybe even bloody, though the appearance can vary. Sometimes it's greenish early on. This massive fluid buildup is why the stomach gets so distended and painful.
Yeah, well.
Then, as the condition progresses, horses become increasingly depressed and lethargic, just dull, not themselves.
Right.
This is because of the dehydration, the systemic reaction to bacterial toxins, that's the endotoxemia we mentioned, basically toxins overwhelming the body and severe electrolyte imbalances. In fact, a horse with DPJ often looks more depressed than outwardly painful, especially after their stomach has been decompressed.
Interesting. More depressed than painful.
Yeah, it's a characteristic shift sometimes. Fever is common too, usually between, say, 101.5 to 103 degrees Fahrenheit, maybe even higher. It signals that systemic inflammation.
Gotcha.
You'll also see tachycardia and elevated heart rate, often over 60 beats per minute, and in severe cases, it can really soar, up to 80 or even 100 BPM.
Wow.
On examination, you'll hear decreased or maybe even totally absent gut sounds. That's because of the ileus we talked about. The intestine just isn't moving.
Right, everything's shut down.
Pretty much. Dehydration becomes obvious tacky mucous membranes. If you press on the gums, the color takes a long time to come back, what we call prolonged capillary refill time. And a prominent skin tint when you pinch the skin on the neck. In really severe cases, you'll see more pronounced signs of that endotoxemia, like bright pink gums, maybe even a bluish-purple line along the gum margin, what we call a toxic line. Increased respiratory rate, muscle twitching, maybe cold ears and legs.
So you've got these signs, but they could be so many things, like you said. That must be incredibly stressful for a vet trying to figure out what's going on under pressure. What's the one thing, the absolute golden clue maybe, that starts to point them definitively towards DPJ and away from, say, a surgical nightmare?
Yeah, that's the million-dollar question, isn't it?
How do they crack the code? How do they differentiate it from something that needs immediate surgery?
That's the absolute crux of the diagnostic challenge, distinguishing DPJ from a surgical emergency, like a strangulating small intestinal lesion, like a twist or something.
Right.
It's paramount, and it really requires a rapid, systematic approach. It starts with the physical exam. Rectal palpation, for instance, might reveal distended, fluid-filled loops of small intestine. But crucially, with DPJ, these loops are typically less painful when you touch them and noticeably less distended than what you'd usually feel with a strangulating lesion.
Ah, okay. So the degree of distension is different.
Often, yes. With the strangulation, the intestine can feel rock hard, incredibly tight, and the horse reacts violently. With DPJ, it's often more boggy, fluidy. Sometimes you can even feel the thickened, sort of edematous wall of the intestine itself. Abdominal ultrasound is, well, it's a game changer here. It's incredibly helpful.
All right.
It often shows a thickened intestinal wall, especially in that duodenum and proximal jejunum, maybe over 6 millimeters thick, sometimes nearly double its normal thickness.
Wow.
You'll also see those dilated fluid-filled loops of small intestine. But again, critically, while they are dilated, they're generally not nearly as ballooned up, not as severely distended as what we typically see in a surgical obstruction. There, the diameter can be huge, like 8-10 centimeters or more. With DPJ, it might be more like 4-6 centimeters.
So thickened walls, dilated loops, but maybe not as dilated as a surgical case.
Exactly. And the ultrasound will also clearly show that lack of motility, the ileus, in these dilated loops. Plus, you might see an increased amount of fluid just floating around in the abdominal cavity, the peritoneal fluid.
Okay.
And as we already discussed, but it bears repeating, Repeated nasogastric intubation and the removal of those large volumes of reflux that significantly relieve the horse's pain, that is highly, highly suggestive of DPJ.
That pain relief is key.
It's huge. That immediate, often profound relief is frequently the tell that screams medical condition, DPJ, not necessarily a surgical emergency where the underlying problem, the twist or whatever, is still there causing agony.
Got it. What about blood work or other tests?
Yeah, lab diagnostics are important too. A complete blood count. A CBC might show hemoconcentration, basically thicker blood because of dehydration. White blood cell count can be variable. It might be normal, high, or even low, depending on the stage and severity.
Okay.
Serum biochemistry, the blood chemistry panel, often reveals those electrolyte abnormalities we mentioned. Low potassium, low sodium, low chloride are really common.
Right, losing it all in the reflux.
Exactly. You might also see signs of kidney stress from the dehydration, what we call pre-renal azotemia, and usually metabolic acidosis and imbalance in the body's pH, though sometimes alkalosis can happen too. Elevated liver enzymes aren't uncommon either, and elevated blood lactate is a really important indicator of poor tissue perfusion, basically shock setting in.
Okay, so lots of clues in the blood.
Definitely. And then there's abdominocentesis, the belly tap. Analyzing that peritoneal fluid is incredibly important for differentiation. For DPJ, you'll typically find clear to maybe turbid yellow fluid. The protein level will be elevated, often over 2.5 or 3.5 grams per deciliter, sometimes even higher, showing there's significant inflammation leaking protein into the abdomen. But the cell count, the nucleated cell count, is usually normal to only moderately increased, often less than 10,000 cells per microliter.
Okay, so high protein, but maybe not super high cells.
Right. Now, contrast that with a strangulating lesion. There, you'll often get serosanguinous fluid. That means it looks bloody or blood-tinged, because blood vessels in the damaged gut wall are leaking. The protein will likely be even higher, say over 4 grams per deciliter, and the nucleated cell counts are usually significantly elevated, often well over 20,000 cells per microliter, sometimes much higher. That points to severe tissue damage and intense inflammation.
That sounds like a pretty clear difference on the belly tap.
It often is, yeah. It's a really key piece of the puzzle. So to really crack the code, like you said, it's about putting all these pieces together rapidly. The amount and nature of pain relief from reflux, the overall severity of the pain, what the belly tap tells you, what you feel on rectal palpation, and those crucial insights from the ultrasound wall thickness, degree of dilation, motility. It's a fast-paced, detective-like process.
Absolutely critical to distinguish medical versus surgical.
Life or death critical, really, because taking a DPJ case to surgery unnecessarily doesn't usually help and carries risks, while delaying surgery for a true strangulation is often fatal.
That sounds like a monumental task, getting all that information so quickly and making the right call. So, once DPJ is diagnosed, or is the leading diagnosis, what does the road to recovery look like?
Yeah.
What are the key treatment strategies, especially since we know it's primarily a medical condition?
You're right. Treatment is primarily medical and supportive, and it almost always requires hospitalization, usually in a referral or specialized equine clinic, because the level of care needed is really intensive.
Makes sense.
The absolute most crucial life-saving step is that gastric decompression we keep mentioning.
Keep draining the stomach.
Constantly. Frequent nasogastric intubations, sometimes as often as every 1 to 4 hours around the clock, or often leaving in an indwelling tube in place, secured, so fluid can drain continuously or be siphoned off regularly. The goal is to keep that stomach decompressed and prevent it from rupturing, which is a catastrophic complication. And you'll see it, the horse's comfort level, their pain relief, directly correlates with keeping that stomach empty. The tube is typically left in place until the reflux volume significantly decreases, usually down to maybe 1 or 2 liters over a 4-hour period.
So it's not a quick fix at all. You're potentially looking at days, maybe even a week or more in the clinic, just managing that reflux. I can only imagine the worry for an owner during that time.
Absolutely. It's a waiting game, and it's tough. Alongside the decompression, aggressive intravenous fluid therapy is vital. Huge volumes of 5V fluids.
Replace everything they're losing.
Exactly. To correct the severe dehydration, fix those electrolyte imbalances, especially potassium. Potassium levels often plummet in these cases, so we need to supplement it continuously in the IV fluids, often at quite high rates like 20 to 40 milliequivalents per liter. And the fluids also help correct the metabolic acidosis.
Okay, so fluids and electrolytes are key.
Absolutely essential. Then we focus on anti-inflammatory and anti-endotoxic therapies. NSAIDs like flunixin, meglumine, banamine is a common brand name.
Right.
Are used for pain, for inflammation, and they also have some anti-endotoxic properties, helping fight that systemic effect of the bacterial toxins.
Okay.
Other agents might be used too, things like polymyxin B, which binds endotoxin, maybe pentoxifylline or DMSO, to help with inflammation and blood flow.
So attacking the inflammation and the toxins.
Correct. We also sometimes try to stimulate intestinal motility to get that ileus resolved. Prokinetic agents like lidocaine, given as a constant rate infusion intravenously, or metoclopramide, also as an IV drip, can be used.
Do they work well?
Well, their effectiveness hasn't been definitively proven in controlled studies for DPJ, to be honest, and they are absolutely contraindicated, meaning you don't use them if you suspect any kind of physical obstruction, like a surgical lesion. So they're used cautiously, if at all.
Gotcha. What about antibiotics? Are they used?
Yes, broad-spectrum antibiotics are often given empirically.
Meaning just in case.
Pretty much. To combat potential bacterial overgrowth in the static gut, and importantly, to prevent bacteria or toxins from crossing the damaged gut barrier and causing systemic infection or sepsis. Things like penicillin, gentamicin, metronidazole are common choices.
It sounds like a real full-body assault trying to keep the horse stable.
It truly is. It's intensive care. And another really critical piece is remembering that horses with DPJ are at a super high risk for developing laminitis.
Oh, right, the feet.
Yeah.
A terrible complication.
Exactly. It's incredibly painful, often debilitating. So preventative measures are crucial from the get-go. This usually involves cryotherapy, basically continuously icing the feet, keeping them cold, and providing deep supportive bedding in the stall to cushion the hooves.
Makes sense to be proactive there.
Absolutely. Now, during the acute phase, while they're refluxing heavily, horses are kept completely off feed, NPO, nothing by mouth.
Right.
If the case becomes really prolonged, requiring days, sometimes weeks of treatment with no food going in, then parenteral nutrition might be necessary.
Feeding them intravenously?
Exactly. Providing essential nutrients like sugars, amino acids, lipids directly into the bloodstream to prevent malnutrition and muscle wasting, bypassing the gut entirely.
Wow.
Once the reflux finally subsides and their gut starts, waking up, showing signs of motility, then feed is very gradually reintroduced, usually starting with small amounts of palatable mashes or pelleted feed.
A very slow process back to eating.
Very slow, very careful. Now, you asked about surgery earlier. While it's generally not the primary treatment for DPJ itself.
Right, you said it's medical.
It is, but surgery sometimes comes into play. It might be necessary if there's still lingering doubt about whether it could be a surgical lesion and exploratory surgery to definitively rule that out. Or sometimes, if the horse's pain simply cannot be controlled adequately with medical management, surgery might be considered as a last resort, though the prognosis isn't usually great in those cases. And in very rare, super severe cases, surgery might even involve resecting, removing a severely damaged section of bowel. But again, this is uncommon for DPJ and often carries a poor prognosis. It's important to stress that surgery has its own significant risks, anesthesia, infection, adhesions later on, and it doesn't necessarily shorten the course of the reflux or improve survival for straightforward DPJ.
So surgery is usually avoided if possible for DPJ.
Generally, yes. Interestingly, though, even in such a critical state, sometimes frequent, short, gentle hand walks, if the horse is stable enough, can actually be beneficial.
Really? Walking them?
Yeah, just short, slow walks. It's thought to potentially help stimulate GI motility, get things moving again. Of course, only if they're cardiovascularly stable and not in severe pain.
Wow. So even in such a critical state, a bit of gentle movement can actually help. That's almost counterintuitive when you think about a really sick animal.
It can seem that way, but yeah, gentle encouragement of the motility can sometimes be helpful. Carefully managed, of course.
Okay, so wrapping all this up then. Treatment is intensive, multifaceted. What does this all mean for the horse and the owner in terms of outcome? What's the prognosis typically for a horse diagnosed with DPJ? And what are the potential long-term implications if they do survive?
The prognosis for horses diagnosed with DPJ is generally considered guarded to fair. It's serious.
Guarded to fair. Okay.
Reported survival rates, they vary quite a bit in the literature depending on the study, the clinic, the severity of cases they see. But generally, you're looking at somewhere between 50% to maybe 80% survival with intensive medical management in a referral hospital setting.
So better than a coin flip. but certainly not guaranteed.
Exactly. Some studies report survival as high as 90%, which is encouraging, but others have reported rates as low as 25%, maybe in populations with more severe disease or complications. It really highlights the variability.
What makes the difference? What factors point towards a poorer outcome?
Several factors are associated with a poorer outlook, a really high volume of gastric reflux, and especially if it goes on for a long time, prolonged duration. That tells us the ileus is severe and persistent, and the gut is really struggling.
Makes sense.
Also, signs of severe endotoxemia or shock, think marked tachycardia, like that heart rate staying way up high, severe depression, and significantly elevated blood lactate levels. Those are all bad signs, drastically worsening the prognosis.
Okay.
And of course, the development of complications is a huge factor, especially laminitis.
Right.
If laminitis develops, it significantly worsens the prognosis, sometimes becoming the reason for euthanasia, even if the gut is recovering. Other complications like septic peritonitis infection in the belly, aspiration pneumonia if they inhale reflux, or DIC, which is a clotting disorder, those can also be devastating.
And avoiding complications is key.
Absolutely. Also, if the pain becomes refractory, meaning it can't be controlled medically, and exploratory surgery is deemed necessary, that's generally associated with a lower survival rate for DPJ itself. It usually means the condition is unusually aggressive or perhaps something else is going on. And sadly, we have to mention financial constraints. The treatment is intensive, requiring hospitalization, continuous fluids, medications, round-the-clock monitoring. It's frankly very expensive. And sometimes economic limitations become the deciding factor.
That's a tough reality. So it's a long, challenging road, but many horses do pull through with that intensive care.
Yeah.
What about after they leave the clinic? Are they completely out of the woods then?
That's a great question. The good news is that many horses that survive DPJ can absolutely return to their previous level of performance, whether that's pleasure riding or competition.
Oh, that's fantastic news.
It really is. However, some horses may experience recurrent episodes of colic later on, or even, unfortunately, repeat bouts of DPJ. It's not super common, but it can happen. Others might develop chronic weight loss or have trouble maintaining condition, maybe due to some ongoing intestinal dysfunction or subtle damage. And adhesions.
Ah, the scar tissue.
Exactly. Scar tissue that can form between loops of intestine after severe inflammation like this. That's a potential long-term complication. And those adhesions could unfortunately lead to future episodes of surgical colic down the line, sometimes years later.
So potential long-term impacts to be aware of. How long does the reflux typically last? You mentioned it could be prolonged.
Yeah, the duration can be quite variable. It can be as short as just 24 hours in milder cases, but typically it lasts for about 3 to 7 days. Sometimes, though, it can go on for longer, even weeks in really stubborn cases.
3 to 7 days seems like an eternity when you're dealing with it.
It absolutely does. Generally speaking, we see a better prognosis if the reflux stops within about 72 hours within those first 3 days. If it persists much longer than a week, the odds tend to decrease, and the risk of complications and costs go up. And sadly, as I touched on, if a horse doesn't make it through an episode of DPJ, it's most often due to either that sheer financial burden of the extensive treatment becoming unsustainable for the owner, or because of the development of severe, unmanageable complications like laminitis, peritonitis, or sometimes adhesions leading to intractable problems.
That was a truly comprehensive exploration of a very serious and complex equine condition. It really reinforces that equine duodenitis proximal jejunitis is a challenging illness, no doubt about it. But with vigilant, dedicated, intensive medical management, many horses do have a good chance of recovery.
That's right. Early recognition and intervention are key.
So, thinking about what we discussed earlier, knowing how something like a sudden dietary change can potentially be a risk factor, and understanding the critical role of the gut microbiome. Here's a final thought for you, the listener. What small preventative steps could you potentially take in your daily animal care, perhaps in unfeeding or stress management, to help support gut health, and maybe, just maybe, avert such a severe medical emergency for the animals in your life? Something to mull over.
Yeah, and if we connect this to the bigger picture, it just profoundly underscores the incredible interconnectedness of an animal's entire system, doesn't it?
It really does.
It shows how a seemingly localized inflammation just in one part of the gut can so quickly cascade into a life-threatening systemic crisis involving multiple organ systems. And it also highlights how our understanding of these intricate relationships, especially involving the microbiome and inflammation, just continues to evolve.
A fascinating and sobering look at a critical condition. Thank you for joining us for another in-depth look into the fascinating world of knowledge.